Good. Welcome back to Walk with the Doc. It's September 18th, 2019. A little chilly start to the morning. Great for heated seats when you're driving in too. But it's going to be a beautiful day and a beautiful week coming up. So today you have Dr. Ruenes. Many of you know him. This is also Prostate Health Month.
It is Prostate Cancer Awareness Month.
Okay, perfect. So even for the ladies in the audience, good topic to know about, and he'll touch on robotics too, which many of you probably have heard about as well. Dr. Ruenes has been here 25 years, Doylestown Health, and he'll tell a little bit more about his background. I'm sure many of you know he's been at the hospital, and his office is right across the street as well too. So, Dr. Ruenes.
Well, good morning. Thanks for coming out. Nice to see some familiar faces and some unfamiliar faces. It's hard to believe that after 25 years here in town, there are still folks that I don't recognize by face. My name's Ruenes. I'm a board-certified urologist. As Dr. Comezzo said, I've been here in the community for 25 years. Came here right out of my surgical training, which was down at Duke University. I went to medical school at Columbia University in New York City, not far from where I grew up. Undergraduate college, I was down at William & Mary in Virginia. The reason I'm here in Doylestown is that while I was down at Duke, I met my business partner, Steve Flashner. I work with we're a total of 4 urologists. We all met at Duke during our surgical training. We all went to different undergraduate colleges and different medical schools. But Steve Flashner's our connection to this area. He grew up in Northeast Philly. And when he left Duke a couple years before me, he made me promise that before I took a job anywhere that I'd come see him in Doylestown, where he planned to start his practice. He said it's kind of a little sleepy town, but it's a little gem, and it's a place where we can maybe hitch our wagons to a star and make a future together. And it's just been a wonderful experience. I've been here through most of the phases of the growth of the hospital. I've had Dr. Comezzo, and it's remarkable what's taken place in just the last 2.5 decades. When I came to interview here, Bruce Derrick, a general surgeon who's since retired, said, "Look, you're coming from a university hospital. This is a small community hospital, but whatever you guys decide to do and whatever technologies you can add, we'll support you as best we can." He and the hospital administration have kept their word, and as Dr. Comezzo alluded to, here at Doylestown Hospital, we now offer robotic surgery in a lot of disciplines, not just urology. In urology, robotic surgery is very well applicable to the treatment of prostate cancer. We offer a number of different approaches to prostate cancer surgery here at the hospital, most of them minimally invasive. But the bigger question about prostate cancer is how does someone get to that point where they need treatment? So back in 1994, just as I was kind of in my chief residency year at Duke, PSA, a blood test that many of you are familiar with, came into vogue. So at the beginning of my surgical residency, it would not be uncommon for us at Duke University, a big regional hospital down there, to do about 3 or 4 prostate operations a month. When I left my residency, we were doing about 8 a week. And it had in large part to do with the use of that diagnostic tool, which was helping us recognize prostate cancer earlier. Now, a lot of you know there's some great controversy surrounding PSA. Clearly, what's not controversial is that blood test has certainly impacted the mortality from prostate cancer, the death rates from prostate cancer. It's helped us recognize cancer earlier, so we stem the spread of that cancer. Prostate cancer still, to this day, the number 3 leading cause of death among American men. About 160 to 180,000 men a year in this country are diagnosed with prostate cancer, and about 35,000 will die of it each year. PSA blood testing is one of those tools that can help us determine which men need to be evaluated further. So typically a fellow should, between the ages of 55 and 70, every year have a prostate exam, a finger in the backside to feel the health of the prostate, and a blood test. If those tests are both normal, there's no indication that a fella needs any further testing. And then after age 70, 75, if there's not a lot of risk factors for prostate cancer in that fella's life, probably that screening can be discontinued. For African American men and for men with a family history of prostate cancer like I have, screening is usually begun about 5 years earlier, age 45, and probably should continue through to age 75. Now, I think the biggest controversy comes when we talk about treatment of prostate cancer. And a lot of people suggest that we're overdiagnosing prostate cancer. And I'd argue that we can't overdiagnose a condition. It's as prevalent in the community as it is, but we certainly can overtreat prostate cancer. And probably in the last 5 to 7 years, what we're really looking to do is to determine which men with prostate cancer need aggressive treatment and which men do not. And it might sound unusual, well, if you have cancer, you need treatment. Well, some prostate cancers are at the time of diagnosis and will remain very indolent, meaning the likelihood of them killing a fella is very low. Through some of the genetic testing now that we're doing, we're getting better and better at determining who needs treatment. Who, in other words, if we don't treat, would go on to have spread of their disease and complications. And of those men that we don't treat, who are the ones most likely to do just fine and ultimately, bless you, ultimately die of other causes? So that's the real focus of where we are right now in my field. And with the use of MRI, a new modality that we're applying to the evaluation of men with an elevated PSA, a high prostate specific antigen blood test, and through how we're looking at the tissue that we obtain from a biopsy that confirms the cancer, we can make some of those predictions. Now, on examination alone and with the prostate blood test and the biopsy, we pretty much know which men are at risk for progression of their disease. When a pathologist, the doctor who looks at a biopsy under a microscope, when a pathologist looks at that tissue, they give us what's called a Gleason grade. So when you talk about cancers, you have grade of the cancer, which tells you how relatively aggressive that cancer is, and this applies to all cancers, not just prostate cancer. And then there's the stage that we hear about. You know, is it localized or is it advanced? A biopsy tells us nothing really about the stage. It tells us more about the grade, how aggressive that cancer is. And on a scale, we now have kind of these groupings, a group 1, a group 2, and a group 3. I think everybody's in agreement that anybody with a group 2 or 3 cancer with a life expectancy at the time of diagnosis of at least 10 to 15 years should be treated. So there are some men who see me and they have a fairly aggressive prostate cancer, but they've had 7 heart attacks, they have emphysema, they're on oxygen, they've had 2 strokes. The likelihood of that man living 10 years from the time of diagnosis is not good. So we would probably, in that case, even with an aggressive cancer, tend to watch it knowing that his other medical conditions will probably bring the end of his life sooner than the prostate cancer would. So it's all about trying to match the aggressiveness of treatment to the aggressiveness of the cancer. And we're getting much better at doing that. And most of it has to do with our ability to look at the tissue and at certain blood tests to check for certain mutations. There are also some people, so breast cancer and prostate cancer have a lot of parallels. About 7 to 8% of all women in this country will develop breast cancer over the course of their lifetime. And it's the same numbers with prostate cancer. As we get older, breast cancer becomes more prevalent. As we get older, prostate cancer becomes more prevalent. And both cancers can be manipulated or treated in part through hormonal evaluations and management. So there are a lot of similarities between those 2 cancers. A lot of men with prostate cancer now are getting genetic testing because perhaps their mother or their maternal aunt had breast cancer, or their sister had breast cancer. There's a history of ovarian cancer. There's something called the BRCA gene. And a lot of women who have breast cancer, they're tested for the BRCA gene. Well, we're starting to test men also with prostate cancer for the BRCA gene, because studies also show that those men that have that mutation are also at risk of progression of their prostate cancer from the time of diagnosis. So all of these kind of genetic tests that we're using more and more commonly now will give us more information moving forward. So to touch on robotics just briefly, robotic surgery is a way to perform fairly complex intra-abdominal and pelvic surgeries and chest surgeries using laparoscopic technique. So basically, this is what we call kind of keyhole incision surgery. A number of small incisions on the abdomen or in the chest, depending on the scope of the surgery. And then we introduce these instruments through trocars, through kind of tubes. What robotics has allowed us to do is it's given us more manual dexterity with those instruments. And if you were to step into our operating room tomorrow and watch us do one of these procedures, you'll see that the patient is on the OR table, just like normal. There are a number of laparoscopic instruments in that abdomen, which is common to laparoscopic surgery. But what's unique is that the surgeon is the only one not at the table. The surgical nurse is there, the surgical assistant is there, but the surgeon is in a console about 15 feet away, which is connected electronically to a machine that then directs the movements of those laparoscopic instruments. 10 years ago, before the advent of robotic surgery here, laparoscopic surgery was done with all the surgeons at the table, moving the laparoscopic instruments themselves manually. Now there's an interface, and that allows us to kind of do more precise, more elaborate, more complicated laparoscopic procedures. It offers some magnification to the surgical field, so in certain ways and in certain procedures it offers great advantage. And so a lot of people have this misunderstanding or this conception of robotic surgery as, you know, you hook the machine up to the laparoscopes, you push a button, and it's all calculated and based on algorithms and x-ray results that the surgery is done by the robot. And so there are fewer mistakes. Well, it's not that at all. Basically, this is robotic-assisted laparoscopic surgery. Again, a very common technique for surgical procedures, but the advantage is we've got this interface, this mechanical robotic interface that allows more precise movements of the instruments, actually mimics the surgeon's hand motions. So it's a nice way to do that, and in terms of advantages, the greatest advantage of robotic or laparoscopic surgery is a shorter recovery time, a shorter hospitalization. So again, robotic surgery is just one of the ways we do prostate cancer surgery here at Doylestown Hospital. We offer 3 different approaches, and we try to match the approach that's most suitable for each individual patient, so we don't paint all prostate cancer patients with a broad brush.
Terrific. Any questions for Dr. Ruenes?
Yes, sir.
Prostate cancer spread beyond the prostate.
Yes. I'm sorry? The question?
Prostate cancer.
Yes.
Can it or
Yeah.
spread beyond?
Yeah, like just about all cancers, prostate cancer can spread beyond the prostate. Typically when prostate cancer spreads, it first spreads locally into some of the tissues right around the prostate. You know, the prostate sits just at the base of the bladder, just in front of the rectum, and above the sphincter muscle that provides men normal urinary control. So prostate cancer can spread to some of those local tissues. Typically it spreads to the lymph nodes, like a lot of cancers first. Prostate cancer is one of the more common cancers that we get that can spread to the bones as well. So here we were talking about, you know, diagnosis and treatment of localized prostate cancer. One of the, perhaps arguably the greatest advance in the treatment of prostate cancer in the last 5 years is our ability to treat metastatic or prostate cancer that has spread. We're getting better and better at doing that as well.
Thank you.
Yes, sir.
And robotic assisted surgery, why is the recovery time shorter?
The recovery time is shorter because the incisions are smaller. It's all about post-operative pain management and the need or the lack of need for bed rest. It has nothing to do, the procedure is the same regardless of the approach used.
This lady over here.
Yes.
Not necessarily just here in Doylestown, but do you see a correlation in males between prostate and breast cancer, the BRCA gene connection?
Yeah, we do. I think the current recommendations are that any gentleman who has a strong family history of breast or ovarian cancer in the women in their lives should be checked for the BRCA gene. And if they have it, the idea is that they certainly need to be under surveillance, for those common cancers associated with that genetic abnormality.
What cancer did Gary Papa?
Gary Papa had prostate cancer.
By what?
Yeah, so I don't know all the details, right? Because some of that was kept out of the press. But clearly, Gary Papa was one of those, very unfortunate men who was diagnosed with a tremendously aggressive prostate cancer at a young age. And despite all treatments, his cancer progressed to the point where he developed metastatic disease and then ultimately died of his prostate cancer. So, there's that. So we talked about PSA. PSA came out in 1994. Like I said, there was a dramatic decrease in the number of metastatic prostate cancers we saw after that. But then there was a big uptake in prostate biopsies and prostate cancer surgery and some of the complications associated with those maneuvers. There's something called the U.S. Preventative Services Task Force, and they're the ones that, year after year evaluate things like screening colonoscopy, mammography, all kinds of testing for different cancers. And I think it was 2014, they came out and gave PSA testing like a failing grade. And they said we shouldn't even use it because what this test appears to have done is to just put more men in harm's way, and we're really saving very few lives through this screening. Just 2 years ago, they revised that and they upgraded PSA because they realized that was probably, you can't throw the baby out with the bathwater. And there are some men who certainly benefit from screening and early detection. Arguably, Gary Papa was going to die of that disease just because of the severe nature of it.
Wonderful overview. Thank you.
No.
Great.
Thanks.